Hello everyone, this is Shad Reis from ARCH 2022. With me is Dr. Arthur Reitman. He is from Wellstar Health System. We're going to talk today about the calcified lesions. Multiple technology came up, and it's still a challenge really with the cohort of patients we have now. So what do we have now in the toolbox?
You know, I think it's interesting as we start to think about ways that we can improve long-term outcomes for our patients. I think that for many, many years we got caught up in attempting to achieve success in a procedure without understanding that the long-term ramifications for many of our patients did not reach clinical equipoise with surgery as we had hoped. A lot of that has to do with our inability to expand stents to the vessel wall, and calcification certainly is one of our greatest enemies as it pertains to that. Right. So I think that in the last session what you heard was really interesting in that many of us are advocating an approach that combines tools such that we're using atherectomy in combination with lithotripsy and non-compliant balloons at the same time. I think we are trying to find ways to minimize vessel trauma and achieve that, that beautiful MSA that we're studying by OCT. So I think understanding that the prevalence of a calcified lesion is so much higher than we can see angiographically when we study this intravascularly or by ultrasound, and recognizing that we have to do more to achieve an optimal result.
Oh, so it sounds like imaging is key in evaluation of the calcium burden in these lesions.
You know, I think Ziad Ali is really leading this movement that really teaches us to look more deeply, if you will, and Dr. Schlafman's before him, to look more deeply and to understand the degree of calcium, the length of calcium. I also have to ask the question whether CTA eventually is going to lead us to a place that we have a better understanding when we walk into procedures what we're going to be doing. So I agree with you. I think imaging is paramount to our success.
So what do you have now in the toolbox? We have orbital, we have rotational, we have shock wave, but I see some operators doing dual modality.
Multiple. I think that this is correct. We, as opposed to when I trained a little while ago where we would step burr and we would try to achieve a lumen, no longer the case. I think that trying to modify plaque, allowing us to create a channel, and then not just changing the conformation of the lumen, but then changing the conformation of the vessel. When you look by CT at what happens after shock wave, the number of fractures, microfractures that are appreciated is amazing. It's truly incredible, and I think that's what allows change in the vessel compliance that leads to really what is our ultimate goal, long-term success with these very thin-strutted stents that can go most places. We just have to make sure that the results are durable over a prolonged time frame.
I think you came across some cases where stent deployed on a heavy calcification that never been modified. Yes. And this lesion going to be there forever, regardless how much you stent through it.
That's right. Yeah. You'll be right back. You'll be right back, unfortunately, and then we really haven't done the patient a real service that we need to do.
Well, Arthur, thank you so much for highlighting the calcification.
Thank you for having me.
Please watch this video and others on the ARCH 22 YouTube channel. This is Shad Reis from Detroit Medical Center. Arthur, thanks again.
Thank you.